Michelle, who's at Cedars-Sinai and the Director of Education in Heart Failure and Transplantation. She graduated from Harvard, received a degree from Yale, training at the Brigham and Johns Hopkins for her fellowship. She has served on many committees for ACC related to heart failure diagnoses. She is the past interim editor-in-chief of the Journal of Heart and Lung Transplantation, and currently an associate editor for JACC, and has received many awards and has published many items, including a book, Mastering the Art of Patient Care. And we're happy and delighted to introduce Dr. Kittleson to address the level of heart failure as it is increasing, and what we can use, what tools and what policies to try to reduce it and improve patient care for these often very ill patients. Dr. Kittleson.
Great, thank you so much. I'm just going to share my slides. I'm going to talk about GDMT and heart failure. To dive in, as you well know, one of the common classifications for heart failure is based on ejection fraction, for better or for worse. That's actually a very important distinction because many of the trials classify patients by their ejection fraction, and therefore our evidence is guided by EF. So we'll start with heart failure with reduced ejection fraction. Spoiler alert, I'm going to tell you at the start, the 4 pillars of survival-enhancing medical therapy for HFrEF are the angiotensin receptor neprilysin inhibitor, the evidence-based beta blocker, the mineralocorticoid antagonist, and the SGLT2 inhibitor. And then I'll spend some time convincing you of the very strong evidence behind these therapies and the rationale for the guideline recommendations. So when we think about heart failure, there are these stages. So like Dr. Blaha, we also care about prevention when it comes to heart failure. Those at high risk without structural disease, those with structural disease without symptoms, but the main focus and our attention is those patients who have structural disease, typically a reduced ejection fraction, and prior or current symptoms of heart failure. And the guidelines give us a dizzying array of things that work. In stage A, we need to control hypertension, diabetes, cardiovascular disease. And for stage B, again, a focus on the guidelines of guideline-directed medical therapy. And for heart failure with reduced ejection fraction in particular, we think about it as a triumph of translational medicine, because it is our understanding of these molecular pathways, these neurohormonal systems that has translated into therapies that help our patients feel better, live longer, stay out of the hospital, and even potentially improve heart function. So let's start with the old stalwart, the beta blockers, which target the sympathetic nervous system, a system that is initially beneficial in revving up that failing heart, but ultimately maladaptive, which is why beta blockers blocking this maladaptive system is so important. And it's pretty clear beta blockers save lives in patients who are less sick, really sick, post-MI, a uniform reduction in mortality with bisoprolol, sustained release metoprolol, or carvedilol. Now, the trials with beta blockers are unequivocal, which is why the guidelines are unequivocal as well. A strong class 1 indication to prescribe one of the 3 evidence-based beta blockers to reduce mortality in patients with HFrEF. The second neurohormonal system we target, of course, is the renin-angiotensin-aldosterone system. Similar theme, a system that is initially beneficial to rev up the heart, to help preserve blood pressure, but ultimately maladaptive in that it leads to hypertrophy, fibrosis, fluid retention. And the story begins with the consensus trial. Now, I'm not going to go through this line by line, but I have to call your attention to consensus. It came out in the New England Journal in 1987, almost 40 years ago. The sickest patients, class 4, only 253 patients, only followed for 6 months, and enalapril reduced mortality from 44% to 26%. It's hard to imagine now a world where your patient with heart failure has a 44% mortality at 6 months. And the reason for that really is the ACE inhibitors. And we know in patients who are really sick, less sick, asymptomatic, post-MI, there is a reduction in mortality. Now, the other way to block this system is the angiotensin receptor blockers, and they're not as good as ACE inhibitors in head-to-head trials, but certainly compared to placebo, they work. And that was all we had really when it came to the renin-angiotensin-aldosterone system, the ACE inhibitors, the king, the ARBs, the second best, until a third neurohormonal system became recognized for its value, the natriuretic peptide system. Now, this system is all good. It leads to more natriuretic peptides, leads to vasodilation, less blood pressure, sympathetic tone, hypertrophy, fibrosis. So we know an increase in natriuretic peptides can help heart failure patients, but you might recall there used to be a recombinant natriuretic peptide on the market, nasiritide. It went out of production because it didn't work. But that might have been because it was a continuous infusion. You shut it off and the benefit went away. But another way to increase these natriuretic peptides would be inhibit the degradation by neprilysin, which is the rationale behind the neprilysin inhibitor component of the ARNI, the sacubitril. So that's the rationale why a medication like sacubitril valsartan would be better than an ACE-ARB alone. And that was tested in the Paradigm HF study, where they took patients with symptomatic HFrEF, not a placebo-controlled trial, an active controlled trial of sacubitril valsartan versus enalapril. And in 2014, the first time since 1987 that the ACE inhibitor was knocked off its throne, and sacubitril valsartan was superior with a reduction in cardiovascular death and heart failure hospitalizations. And the guidelines are very clear about this hierarchy. In patients with HFrEF, ARNI is recommended. ACE only when an ARNI is not feasible, and an ARB only if you're intolerant to an ACE and an ARNI is not feasible. Understanding, of course, that there should be a 36-hour washout so that you avoid angioedema when you combine an ACE with sacubitril valsartan. So that takes us through the ARNI and the beta blocker. What about the mineralocorticoid antagonists? Well, the story begins with the Rawls trial in 1997, and we now know in patients who are less sick, post-MI, a reduction in mortality. But let's look at this observational study highlighted here on the third row. This study was published in the New England Journal in 2004. It looked at prescription claims data and hospital records for Canada patients over 66 years of age, essentially their Medicare database. And I looked at 2 time points, 94 and 2001. Spironolactone prescriptions, hyperkalemia hospitalizations, and hyperkalemia deaths. By 2001, spironolactone prescriptions had gone up, likely because of the Rawls trial, and clinicians were adopting trials into practice and giving their patients spironolactone. But not only did prescriptions go up, so too did hyperkalemia hospitalizations and hyperkalemia deaths. I always highlight this study because it is such an important example of making sure that the patient sitting across from you in clinic is the same patient that accrued benefit in the clinical trial. So some points to make here: eplerenone, spironolactone really, the only difference is that spironolactone will cause gynecomastia and eplerenone won't. And you need to watch the potassium. So this observational study is really an example of the indication creep alert we have to worry about. These older patients in Canada were different than the clinical trial populations. They probably had worse kidney function, worse eGFR for the same level of creatinine, and they also were not as closely followed, which is why the guidelines, based on the strength of the evidence, give MRAs a strong class 1 indication, but also are clear to note we need to be mindful of the eGFR and the potassium to avoid indication creep. So that takes us through three of our pillars: the ARNI, the evidence-based beta blocker, the MRA, and now the final pillar, the magical and mysterious SGLT2 inhibitors that were initially developed for diabetes. They cause glucoseuria, which leads to glycemic control, but also natriuresis, which leads to less blood pressure, better volume overload, and also this mysterious effects on oxidative stress, fibrosis, inflammation, which leading to kidney and heart benefits. Now, what you may not know, one of my favorite stories, is how we figured out how great these medications were. And in fact, we owe it all to rosiglitazone. So as you'll recall, rosiglitazone, a thiazolidine FDA approved in the mid-2000s for the treatment of diabetes because it improved A1C, a surrogate endpoint, when subsequent analyses showed it increased the risk of heart failure, which led the FDA to say any future drug to be FDA approved for diabetes had to be run through the gauntlet of a cardiovascular outcome trial, no surrogate endpoints, clinical endpoints, to document safety. This was bad news for drug companies because these trials are expensive, good news for patients, and it turns out that is why we came up with the important SGLT2 inhibitor cardiovascular trials. EMPA-REG, CANVAS, DECLARE-TIMI 58, VERITAS-CV, all enrolled patients with diabetes and either atherosclerotic cardiovascular disease or elevated risk. And the drug companies had to spend a lot of money on these trials, but they were rewarded for their hard work because these medications were not only safe, they were actually effective. They reduced the risk of cardiovascular death. And not only were they effective for atherosclerotic cardiovascular events, they reduced the risk of heart failure. How mysterious, how unanticipated. So you have SGLT2 inhibitors, which reduced heart failure in diabetic patients who didn't even have heart failure to begin with. Makes you wonder how well they'd work in someone who actually had heart failure. And here is where the clinical trial architects took a genius leap and said, what about in heart failure patients without diabetes? And there, the important heart failure trials were born. DAPA-HF, the shot heard around the world, critically important in patients with HFrEF, no criteria of diabetes for study entry. Dapagliflozin met its primary endpoint of a reduction in cardiovascular death and heart failure hospitalization. The trial came out September 2019, and less than a year later, the FDA extended the indication of dapagliflozin to those patients with HFrEF without diabetes. EMPEROR-HF also met its primary endpoint of a composite of cardiovascular death and heart failure hospitalization, though the secondary endpoint of cardiovascular death wasn't met. Is empagliflozin worse? No. It is a class effect. EMPEROR-HF just enrolled sicker patients as you look at their EFs and their NT-proBNPs and their estimates for event rates. So really think of these as equivalent, prescribe whichever is cheaper for your patient. We also have sotagliflozin, which was inpatient initiation and showing it was safe. So based on the strength of these trials, we have the fourth pillar, strong class 1 indication for SGLT2 inhibitors, regardless of the presence of diabetes. So the bottom line is, with the stepwise addition of the ARNI beta blocker, MRA, SGLT2 inhibitor, we can save a lot of lives, which has built the foundation for this new era of quadruple therapy in heart failure, as highlighted in the guidelines. And in fact, while a purist might say we don't truly have head-to-head data on quadruple therapy versus, say, conventional ACE beta blocker, something circa 2000, we can do a cross-trial analysis to imagine what such a trial would look like. And if you were to pit quadruple therapy against this conventional therapy, you can see there's 6.3 years of lives saved. And there truly is no time for delay. If you look at the landmark trial for sacubitril valsartan, that's on the left, or dapagliflozin, that's on the right, you can see the survival curves separate very quickly. That is the time to start these medications for your patient with HFrEF is yesterday. So those are the quadruple therapy pillars. We also have other stuff out there. We've got fixed dose hydralazine and isosorbide dinitrate, ivabradine. We have soluble guanylate cyclase inhibitors, digoxin. Where do these fit in? Where should we think about them? Well, isosorbide dinitrate hydralazine has a strong indication for those self-identified as African American with severe symptoms on optimal medical therapy, and a very weak indication for everyone else. So why is this? Well, I told you about the consensus trial, which came out in 1987, and you probably thought that would be the oldest trial I talk about today, but you'd be wrong, because I'm going to talk about VHEFT1, which came out in 1986. So back in the 80s, all these heart failure giants knew that afterload reduction was a good thing, lower blood pressure, and that poor, weak, failing heart will have an easier time beating. But they didn't know how to reduce afterload, how to vasodilate. You could use isodyl hydralazine. You could use prazosin, an alpha blocker. So VHEF1 tested these various strategies, and while prazosin didn't work, so no one ever thought about it again, but isodyl hydralazine did. The next great debate among all these heart failure giants was, well, which is better? Is it the ACE inhibitor to afterload reduce, or is it the isodyl hydralazine? VHEFT1 settled that debate very soundly in 1991. Enalapril won, isodyl hydralazine lost, and no one ever thought about it again until 2004 when the AHEFT trial came out, because there were some signals and other analyses that Black patients with HFrEF responded better to isodyl hydralazine. So this trial enrolled patients self-described as Black, severely symptomatic, and in fact, there was a reduction in mortality with isodyl hydralazine and in these patients. So what do we know? We know it's not as good as an ARNI ACE-ARB. That VHEFT1 clearly told us that. And you wouldn't give it instead of an ARNI ACE-ARB, because if you look at the fine print of the AHEF trial to figure out if the patient sitting across from you in clinic matches the trial criteria, you would know that 90% of patients in AHEF were on ACE-ARB, 70% were on a beta blocker. You would know that the baseline systolic blood pressure in AHEF was 120 millimeters mercury. How many patients with class 3 to 4 heart failure have a blood pressure that high? Not many, unless they have a primary hypertensive cardiomyopathy. All of that to say, avoid indication creep alert. Don't look at your patient and say, aha, you're Black, I need to give you isodyl hydralazine. No, say, aha, you have HFrEF. Let me max out my 4 pillars, and if and only if you have blood pressure room to go, should I add isodyl hydralazine, which it turns out is about 2% of patients overall. Digoxin, we love it because It's one of the first drugs ever named after the finger-like projections, the digits of the flowers of the foxglove plant shown here. Very weak indication, may be considered. That's based on the DIDGE trial, which came out in 1997. It was an important trial at the time because back then people thought digoxin killed patients with heart failure, but that was just confounding by indication because there was no randomized trials and doctors just gave it to sicker patients. Now we knew from this trial that it's not harmful, may be helpful, but why such a weak indication? Because 1997 was a long time ago. And back then we didn't have much, and now we have a lot. Now, when it comes to ivabradine, and in fact, because I want to make sure I have enough time to cover HEF, I'm going to flip through ivabradine. Not particularly exciting, but we have to remember to avoid indication creep again, in that it lowers heart rate without reducing contractility. But in the SHIFT trial, which showed benefit, patients were on max tolerated beta blocker. So you don't give it instead of a beta blocker. You give it along with a beta blocker in your patients who still have a heart rate above 70 despite max tolerated beta blocker. Those are the patients who will benefit. Vari-C-Guad is a soluble guanylate cyclase stimulator, which is supposed to do mysterious good things for your endothelial and your vasculature. But spoiler alert, the Victoria trial is not very exciting. Did it meet its primary endpoint of a reduction in death and heart failure hospitalization? Yes, but not very well. Only a 2% absolute risk reduction. So it has a weak indication. Think of it for your patients who have recent worsening of heart failure and are already on guideline-directed medical therapy. But here's how I think about Vari-C-Guad. If you have a patient who's being admitted for decompensated heart failure, yes, there's benefit in Vari-C-Guad in the Victoria trial, but that should be the start of the conversation, not the end of the conversation, because a heart failure hospitalization portends great risk. In fact, 20 to 30% of patients admitted to heart failure die within the next year. So that's the start of the conversation. Let me prescribe this medicine, which may help you do better. But what else should we be thinking about? Are you a candidate for advanced heart failure therapies like transplant? Are you interested in that conversation? Moving on to mechanical solutions, we have transcatheter edge-to-edge repair of the mitral valve. Again, intervention very vulnerable to indication creep. Make sure the patient you are sending for this intervention meets the criteria of the trial that showed benefit COAPT, not the trial that didn't, MITRA-FR, which is why the guidelines say first, have you optimized the GDMT and is the mitral regurgitation still there? Meaning, are they actually bad enough to need it? Because sometimes MR goes away by improving loading conditions. And if they're still there and they have symptoms despite optimizing GDMT, make sure that they're not too far gone. Their LV isn't too low. Their LV size isn't too big. Their pulmonary pressures aren't too high. So it's Goldilocks. Make sure you're just right on the degree of MR and the health of the heart. So moderate to severe MR after GDMT optimization, and the echo meets the EF, size, pulmonary artery criteria. So when we think about it, you have to remember futile versus useful. Now, say you do an awesome job and you get your patient on all 4 pillars and their EF improves, and it very well might, because 30% of patients with non-ischemic cardiomyopathy will improve their EFs, potentially normalize their EF if you max out their guideline-directed medical therapy. So what do you tell them then? Do you say, we can stop all these horrible medicines, your heart's better? Or do you say, you better keep them forever? Well, the TREAD-FH trial shown here helps us answer that question. 50 patients who won the jackpot, improved their ejection fraction, half had GDMT withdrawn, half had it continued. 44% relapsed if their GDMT was withdrawn. And that's only within the first 6 months, mostly because their EF fell or their LV size went up, which is why the guidelines say if your patient is lucky enough to achieve benefit of an improvement in their ejection fraction, continue these medications. Now, you might ask me, well, what if it was a clear insult, like a myocarditis that got better? Really, does it matter? What if they got their stent and then revascularized? That's a data-free zone that requires a discussion about the uncertainty with the patient. The way I look at it is a normal EF is a wonderful thing, and these medications don't have long-term toxicity besides the inconvenience of taking them. So that takes us through the 4 pillars: the ARNI, the beta blocker, the MRA, the SGLT2 inhibitor. Remember, if your patient is Black with blood pressure room after quadruple therapy, then you may consider isosorbide dinitrate hydralazine. If their heart rate's above 70 and they're on max beta blocker, ivabradine, and if they've been hospitalized, varicequat as the start, not the end of the conversation. Now, sadly and sobering, there's the theory and there's the practice. We can see from this study some years ago that guideline-directed medical therapy is not adequately implemented. The green bars are patients on it. The salmon pink bars are patients not on it. About 2/3 not on ACE, ARB, beta blocker, or 1/3 not on ACE, ARB, beta blocker, 2/3 not on MRA. The pie charts show us how many are on 50% or higher of target dose. Red is not, and most are not. That is due to lots of sources of therapeutic inertia, clinicians, systems, patients, which we all are committed so hard to improving. And we now have good guidance to tell us what to do. How do we ramp patients up to maximum therapy? This is classically described in the STRONG-HF trial. 1,000 patients hospitalized with heart failure, and on discharge, they were either randomized to high-intensity care, get them on everything before discharge, and titrated up with very frequent visits, or just usual care. So what do we find? We find that if you're in the high-intensity group, you're more likely to receive target GDMT at 90 days. 55% ACE-ARNI-ARB versus 2%, 49% beta blocker versus 4%, 84% MRA versus 46%. Okay, that makes sense. If you try hard to get people on therapy, patients will get on therapy. That's not a mystery. What's really exciting is the survival curve shown on the right. Patients in the high-intensity group not only were more likely to achieve target doses of medications, they also felt better, were less likely to be hospitalized or die, and there was an 8% absolute reduction in heart failure hospitalizations over 6 months. That's an enormous effect size, and that is just the power of implementation. The IMPLEMENT-HF trial, speaking of implementation, is the American Heart Association's commitment to taking STRONG-HF guidance and putting it through places throughout the United States. And if you look quarterly after targeted educational campaigns, you see an increase in the use of many of these agents. So what's my approach? If I meet them for the first time in the office, I'll try to get them on 4 pillars by 4 to 8 weeks, and then I'll subsequently alternate the ARNI and the beta blocker, getting them to everything else by 8 weeks later. I like to not start everything at once. I like to ensure patients can afford the meds and tolerate them. And if I can't, I'll prioritize the SGLT2, then the ARNI, the rest are generic. Telehealth is a great silver lining of the pandemic, that we can do telehealth visits so that you can quickly ramp up therapy without a lot of expensive and inconvenient visits to the medical center. So that is HEF-REF. Now we're going to talk about HEF-PEF. I'm not going to talk about diagnosis, but I'm showing you this one figure, which I think is incredibly important. HFrEF, it's easy. The EF's low. They have HFrEF. HFpEF is harder. It is a diagnosis of exclusion. So if a patient has dyspnea, edema, and a preserved ejection fraction, first ask yourself, is it the heart's fault? Maybe the congestion is primarily from kidney disease, liver disease, chronic venous insufficiency. It's very hard to unring the bell of misinformation. And if a patient thinks they have heart failure, it's hard to sometimes convince them otherwise. And maybe it is the heart's fault, but there's a secondary underlying cause, like an infiltrative cardiomyopathy, hypertrophic cardiomyopathy, pericardial disease, valvular disease, high output heart failure. I'm never one to advocate for more testing, but I will advocate for more thinking about these underlying diagnoses for which your patient may warrant specific testing and disease-directed therapy. But if you have garden variety HFpEF, where it's typically the older woman with comorbidities of hypertension, diabetes, AFib, obesity, CAD, kidney dysfunction, then you can go on with therapies. There are a lot of things that don't work. Isosorbide dinitrate, irbesartan, perindopril, statins, digoxin, nebivolol, ivabradine, isosorbide mononitrate, sildenafil, serelaxin, and the interatrial shunt devices. But there's also cause for a lot of optimism in things that do work, and we're going to focus on those. I'm going to start with spironolactone, the mineralocorticoid antagonist, initially tested over 10 years ago in the TopCat trial, 3,400 patients, symptomatic HFpEF, randomized to spironolactone or placebo, did not meet its primary endpoint of a reduction in cardiovascular death and heart failure hospitalization, but did meet its secondary endpoint, reduction in heart failure hospitalization. And as expected, patients who received spironolactone had a little bit of a bump in their potassium and creatinine, which MRAs cause. But a lot of people were really, really disappointed by this finding. And they were really disappointed because they really thought spironolactone was going to work. And they thought it so much that they went back and did a deep dive into the data of the TopCat trial. And this was an international trial, and what they found was something quite curious. 50% of patients came from the Americas, 50% came from Russia and Georgia, and the patients in Russia and Georgia were very different. First, their point estimates for their event rates, death and hospitalization, was mysteriously low in the 20s in the Americas, 2-3% in Russia and Georgia. The other strange thing, about half of the patients from Russia and Georgia, they didn't bump their potassium and creatinine when they were ostensibly on spironolactone. So this is a real disappointment that the trial as a whole might have been a wash, because half the patients in it might not have had heart failure and might not have received spironolactone. And that is why, sadly, the guidelines gave spironolactone a 2B weak indication, because the pivotal trial didn't meet its primary endpoint. But some of us always believed in spironolactone, and if this talk was a year ago, I'd have had to end it there. But now I have more data from the Fine Arts trial with finerenone, a different mineralocorticoid antagonist, which, like in the TopCat trial, took patients with symptomatic HFpEF. This trial met its primary endpoint of a reduction in cardiovascular death and worsening heart failure. So we have to ask ourselves, well, finerenone, spironolactone, what's the difference here? Well, the authors of Fine Arts will tell you that finerenone is a non-steroidal MRA with physiochemical properties that are distinct from spironolactone, balanced distribution, short half-life without active metabolites. So really, is the Fine Arts trial a triumph of finerenone, or is it a vindication of cheaper, generic spironolactone? Sometimes when I don't know the answer to a question, I go to Twitter and ask my closest friends, and I did in this situation. I wanted to know, what did people think, Fine Arts versus TopCat? Well, 523 people chimed in. It was pretty much an even split, which I think reflects the general uncertainty. And here's my take. Perfect is the enemy of good, meaning Finerenone's perfect. It's clinical trial evidence. But spironolactone is good. So don't make your patient mortgage their house to afford their finerenone. Save their money for an SGLT2 inhibitor, as we'll talk about in the next slide. So I would feel very comfortable and at peace prescribing spironolactone for HFpEF patients. Speaking of SGLT2 inhibitors, we have two beautifully congruent trials, Emperor Preserved and Deliver, that show that both empagliflozin and dapagliflozin, when given to patients with HFpEF, reduce the primary endpoint of cardiovascular death and heart failure hospitalizations, also good for the kidneys. The guidelines give SGLT2 inhibitors a 2A indication, and you'll say, hold up there. You've got two congruent trials. That should be a class 1. You are correct. It should be a class 1. But the guidelines were published in 2022, at which point only one of these trials had come out. So that is why it was a 2A. But really, I think in our hearts that SGLT2 class 1 strong indication. The story with ARNIs is not as exciting in HFpEF as it is with HFrEF. We have the Paragon-HF trial, which showed no difference in the primary endpoint of cardiovascular death and heart failure hospitalization of sacubitril/valsartan versus valsartan. Also, no difference in the secondary endpoint of heart failure hospitalization. Now, a lot of pundits were saying, well, if there were 7 more events in the placebo arm, heart failure hospitalization would have been significant, but there were not 7 events in the placebo arm, so it's hard to wish and make it so. There's a signal in women, lower EF, that ARNIs are beneficial, but because the trial did not demonstrate a benefit, ARNIs have a weak 2B indication. So how do I think about them? Not de facto, like MRAs and SGLT2 inhibitors, but these patients are often hypertensive, and if you have an excuse that you need to lower blood pressure, you can give an ARNI. You'll be doing 2 things, lowering their blood pressure and potentially improving their HFpEF outcomes. Ditto for the angiotensin receptor blockers. Charm Preserve, now over 2 decades ago, showed a benefit of candesartan and HFpEF. Subsequent trials did not show that. That's why there's a weak indication. But think of it as a first-line blood pressure agent you may need anyway in your patients with HFpEF. Now, a talk about HFpEF would not be complete without a discussion of exercise and weight loss. I love this bar graph on the left. 100 patients with HFpEF, average age 67, average BMI 39, randomized to calorie restriction, cut out 400 calories a day, exercise training, basically cardiac rehab. Both of these options improved peak VO2 with an additive benefit, and calorie restriction also improved quality of life. As the forest plot on the right shows, this benefit of exercise has been shown consistently in multiple trials. If you exercise and lose weight with HFpEF, you will feel better. Your functional capacity will be better. And if I was giving this talk a year or 2 ago, I'd end by saying, but weight loss is really hard and hard to help patients achieve. But now we have the incretin-based therapies, the GLP-1 and the GIP receptor agonists, that not only treat diabetes, but also help the stomach and the brain to reduce satiety and promote weight loss. We know in HFpEF, from the STEP HFpEF trial, that if you give patients with HFpEF, median BMI 37, semaglutide for a year, they will lose about 13% of their body weight, feel better, walk longer. So the question is, are you just helping someone feel better because they lost weight? Is there some HFpEF specific benefit? It's hard to know. In this subgroup analysis of the original trial that was simultaneously published in Nature with the original trial, the more weight you lost, the better you felt and the farther you walked. So STEP HFpEF was interesting, but it wasn't necessarily earth-shattering. But there is more. There's a Summit trial, which took it a step farther. Tirzepatide, a dual agonist to HFpEF patients, and they had, wow, about a 15% reduction in weight loss, more effective, as we know, than the single agonist. And there was also a reduction in the time to first occurrence of heart failure outcomes. So this is exciting. This is exciting that it appears there's a benefit beyond weight loss for patients with HFpEF who are obese who take these incretin-based therapies. However, I still have tempered enthusiasm. No difference in death, very low event rates, short follow-up. And now I'm going to show you something hot off the press. I was honored to chair a scientific statement from the AHA on heart failure and obesity, which just came out a week ago. And in it, we discuss weight loss strategies in heart failure, which include, of course, behavioral changes, diet and exercise, as ineffective as they often are, the anti-obesity medications, as well as not forgetting the role of metabolic and bariatric surgery, where now we have anti-obesity medications which approach the efficacy of these surgeries, but remembering that this is also an effective long-term option in selected patients. So when we think about the 2022 guidelines and what they say about HFpEF, diuretics were a necessary evil and everything else was, yeah, maybe, meh. But how the field has evolved, because this was 2022. Then in 2023, we published a consensus statement on HFpEF. I chaired that document, and we said SGLT2 inhibitors for everybody because the data is evolving. The guidelines are now out of date. And think about the loop as your necessary evil and all these other therapies. This was 2023, and how amazing. It's already out of date. So if I were to redo that figure in 2025, I'd say SGLT2 inhibitor and MRA for everyone, loops a necessary evil, have an elevated BMI, go on your incretin-based therapy. And if you have high blood pressure, especially if you're a woman and you need an excuse for something to lower it, ARNI if you can afford it, ARB if you can't. So in summary, for HFrEF, quadruple therapy of ARNI, beta blocker, MRA, SGLT2 inhibitor saves lives. The ARNI is better than the ACE is better than the ARB. And every patient, we ask ourselves, if they're not on quadruple therapy, why not? Can it be titrated? When it comes to HFpEF, remember it's diagnosis of exclusion. One, is it the heart's fault at all? And if it is there an underlying cause like amyloidosis? SGLT2 and MRA for everyone, and manage your comorbidities, because it's important to remember that it's not just great science that saves lives. The proper equation is great science, and effective implementation equals lives saved. So thanks so much for your attention.